forensic pathologists. In other words, when a forensic pathologist trainee, what we would call a fellow, is doing a case, I would be directly supervising everything that they did on that case. And it would be my responsibility to ensure that that case was done correctly. And so it's almost like an apprenticeship, and they are standing, they're going to do the case, but you're going to be watching carefully and evaluating every single part of that process as they gradually grow through that learning curve to become a forensic pathologist. So for a while I was hands-on actually teaching at the autopsy table. When I became deputy chief, I continued to do that, but one of the roles that was assigned to me was the residency director position for the office. And so that is the position where you supervise the residency program and how that program is accredited and evaluated by an outside agency, so you have to make sure that all of those requirements are done. So that's just an additional layer on top of that.
So were you responsible for recruiting the residents and things of that nature?
Recruiting, evaluating, bringing them in, and then obviously training, evaluating. And at the end of the process, each of those fellows, before they can take the board exam in forensic pathology, require that the institution complete a declaration that they have met the standards in order to practice. And that is before they can take the exam. So they are constantly evaluated daily, quarterly, and then at the end of the year to ensure that they have met the standards that we can attest to, so they are then qualified to take the examination through the American Board of Pathology.
And you've testified in cases before?
Yes.
State and federal?
Yes.
Civil and criminal?
Yes.
Can you estimate how many times you've testified in cases over the course of your career?
Gosh, over the 30-some years, it's hundreds and hundreds and hundreds of times.
Now, have you ever published any articles or peer-reviewed journal type information?
Both publications and presentations I've been involved. Publications, it has to be closing in on 100, but I haven't looked at my CV and counted them recently.
Okay. At the Office of the Chief Medical Examiners, do you review every homicide?
That was the policy, that the chief would get to review all homicides, all pediatric cases that were under the age of about 2 years, and then any case which the medical examiner could not determine the cause of death.
Okay. And how many homicides did you review?
Typically, the number of homicides in Maryland each year would vary between 500 and 600. So that would be the homicides alone. And then the other cases that added on to that would add an additional load of perhaps 50 to 100 cases.
Okay. So in this capacity, in this case, are you associated with an organization called the Forensics Panel?
Yes.
Can you just generally describe what the Forensics Panel is?
The Forensic Panel is a national organization that not evaluates, but it looks at cases and does evaluations on cases in the forensic sciences, the medical sciences, and the behavioral sciences. So it's a forensic science organization that looks at those particular issues.
What is your role with the Forensics Panel?
I am a forensic pathology consultant.
In terms of the Forensics Panel, what's unique about how that organization operates?
So the Forensic Panel really started the process of peer review evaluations in order to ensure that the case was diligently evaluated, objectively evaluated, and was based in the known science. So that's the first thing, and it's peer review, and that has evolved over time. Then it's an organization which has many different disciplines recognized or that are recognized working within it. So it's a multidisciplinary team. So you have experts in all sorts of medical fields that can be assigned to the case depending on the nature of the case. It's an independent organization.
Is it similar to what's called an M&M conference?
A mortality and morbidity is what you're referring to. That is something very similar that happens in the average hospital when a patient may have something adverse happen to them, not necessarily fatal. That's the morbidity part, or it is fatal, mortality. And in those circumstances, physicians will present in a closed environment all of the materials and their evaluation, and the general physician population that have gone to that conference can sit down and critique it, evaluate it, and it's an opportunity for self-evaluation, learning for people, and quality assurance for the hospital program. Yes, it's similar.
How did you end up working within the forensic panel, and when?
About 15 years ago, I was approached by the forensic panel, and they indicated that another forensic pathologist had recommended me as somebody who might well fit their program.
And so within the panel there, you described it as a multidisciplinary approach. How does that function?
So, depending on the nature of the case, the forensic panel will assign individuals that have skills in areas that the case apparently needs from an evaluation process. So,
and you're compensated for your time?
I am.
And your hourly rate?
It's $350 an hour.
You at some point became involved in this case, State of Minnesota versus Derek Chauvin?
I did.
And how did you become involved in this case?
The forensic panel, I was approached and asked to become part of it, and I felt that this was such a complex and difficult case that this would better fit working through the forensic panel than trying to handle this case independently. So I referred this case to the forensic panel.
And you were approached by me, correct?
I believe that was the first conversation I had, yes. It was a while back.
And you referred me to the forensics panel?
That's my recollection, yes.
Now, in terms of this particular case, how many of these peer reviewers were ultimately involved?
There were 13 peer reviewers across multiple disciplines that were involved in this case.
How is it useful for you to have those peer reviewers involved?
Well, several of the peer reviewers, I believe 7, are forensic pathologists, so my direct colleagues with the same training and skill set that you'd expect a good forensic pathologist to have. There were additional individuals in behavioral health, pulmonologists, emergency room physicians, toxicologists that were present as part of the evaluation team, because they have the detailed knowledge in those other areas that really helps critique any opinions that I may form and provide their expertise in ensuring that everything was looked at and that any opinion that is expressed is based in science.
What's the process that you apply in approaching a case such as this?
So the primary reviewer in a case like that will be provided all of the available information that has been given to the forensic panel. They will go through that material, study it, evaluate it, and then the peer reviewers are given a similar but sometimes slightly less onerous package of materials, but they are given similar materials. They will go through it, and then I would, in this case, as I did in this case, I've been a review pathologist on several, and in this case I was the primary. I will do a presentation to the forensic panel, and during that time they have the opportunity to evaluate and critique my opinion. Based on that, if there's additional information that is necessary, in order to help refine the opinions. That request can go back to the forensic panel and through to whichever attorney, whether it be a prosecutor or a defense attorney, a plaintiff's attorney, or a defense attorney. Requests for the appropriate additional information can be made, and if that information is available, sent back so we can complete and try and ensure that we haven't missed anything. So there may be several reviews along the way, and then at some point, if the
Objection, Your Honor, to the narrative nature of the response, and
Sure.
could we, Your Honor, approach the bench?
Cyber.
Whose that is.
All right. Dr. Fowler, are you familiar with NAME?
Yes, I am.
And what is NAME?
NAME is the National Association of Medical Examiners.
And are you a member of NAME?
I am.
Have you held any leadership positions in that organization?
I have, yes.
Can you, well, let me ask you this. Does NAME have an inspection and accreditation process?
Yes, it does.
Or committee, I should say.
Yes, it has a committee which does that particular task for the organization.
What is the responsibility of the inspection and accreditation committee?
To evaluate medical examiner and coroner officers. It's a voluntary program, and basically it means that the medical examiner's office, once they've passed that evaluation and been accredited, have met certain standards that the National Association of Medical Examiners Board of Directors believe are appropriate for the office to have in order to ensure the safety of both the staff that work in the office and also the community that they serve.
Are you a member of that committee?
I am now, and I was a previous chairman of that committee.
Does NAME have a standards committee?
It does. Right now they are two separate committees.
And
Previously they were both inspection and standards were under one committee. At the time I was the chairperson of that. I chaired
And
the
how-
entire, but it's
how-
now been separated off into two separate ones.
Gotcha. How are the standards approved?
So the standards are different. As I said, the accreditation checklist is approved by the board of directors. The standards are a grassroots process where any member of NAME can suggest a standard. That is then put out to the the general population of members of name, and then those are discussed and voted on at the annual general meeting in the business meeting. And so therefore, anybody out of the hundreds of pathologists that are present at that meeting can stand up and address and debate those particular standards, and then at some point a vote is called by the chairman of the standards committee as to whether or not that standard would be included or not. And so therefore it's approved by the general membership, not by the board of directors.
And one last question before we move on. When were those standards approved?
The initial standards started out in 2005, and then they get updated on a regular basis because medical knowledge changes, and therefore one needs to keep them appropriate and fresh.
Can you tell me generally what a death investigation is and what it involves?
Yes, a death investigation is very much like any other medical examination, but specifically looking at individuals obviously who have died. So there is gathering of information from the scene of the death, and that is somewhat to replace the information that a patient would give to their doctor. When you walk into the examination room, your doctor, the first question they'll ask you is, why are you here today? Well, deceased people can't speak. And so therefore, the scene information really replaces some of that information. You gather the scene information, you gather past medical records, you then start gathering information from all sorts of pertinent sources. That will be the ambulance or EMT run sheets, the hospital information if the person made it to the hospital, the current medical information, the past medical information. There will be witness statements, there will be police records, videos, everything that is available and pertinent will usually be gathered as part of that process.
Would it also include things like specimens that are collected?
Yes, so if a specimen is taken in the hospital, that will be taken. If clothing is available in the hospital and removed from the person during resuscitation, that may well be gathered as well. You know, all and everything that is reasonably available that could potentially define how the case may be evaluated at the end will be gathered as is reasonable. So yes, hospital specimens. If the person, for instance, went into surgery and a specimen was removed from them during the surgical procedure to try and save their life, that would also be requested. So there's lots of things that you would try and get.
And is there then, ultimately it results in a death certificate?
Well, there's a long process which goes on before that.
How long does that process take?
So you know, the process would include an autopsy, which is an external examination of the person, an internal examination of the person, maybe x-rays of the person, CT scans of the person, depending on the resources and needs of the case. Additional specimens will be taken at the time of autopsy to look at under the microscope and or send off to a toxicology laboratory. And I'm talking very generally. Every case is going to be different. At the end of that process, you begin the evaluation of the case. In complex cases, certain specimens will be retained and often sent to an expert in that particular area. So some officers have access to a neuropathologist who specializes in looking at brains and spinal cords. So if you have that resource and it's a case where that really may well assist in getting the additional detail that a specialist who only looks at that can provide, then you'll save that specimen and have them look at it in conjunction with you. So it's usually an examination of the two with that extra expertise at the same time.
Are there other factors or other processes that occur?
Yes, and you know, some offices have access to cardiac pathologists. The Maryland office does, and so in many of these complex cases, the heart would be retained and examined by a cardiac pathologist. And you have in fairness, a general forensic pathologist has a substantial body of knowledge and is very good at identifying most things. But there are cases when somebody who only looks at that one organ is going to have a better eye for detail in that particular area. And so you can do that. Not all officers have access to those resources, but if you have, that's a good thing. So those all add time to waiting for those examinations to be done and the results to be sent back so they can be put into the evaluation matrix and the jigsaw puzzle of all of the information that you're trying to include, as well as the toxicology results, which take a while to come back, the microscopic examination, which the pathologist will do themselves. It takes a while for the glass slides. So some cases can take 2 to 3 months. And NAME actually has a requirement that you should complete 90% of your cases within 90 days. Otherwise, you cannot be accredited. They prefer you to do it within 60 days, but 90% of cases should be completed within 90 days. And that's 3 months. And the 10% of cases that aren't completed with it are going to be very complex cases. Often the deaths in custody and the pediatric sudden deaths are the ones that fall into that 10%. So they often go out even further as you gather all of that information.
Thank you. So can you explain what the death certificate is? Ultimately, a death certificate is issued, right?
Correct.
And can you explain what the death certificate is?
So the death certificate is a document that is produced by a physician. The greater majority of them are signed out by physicians within the hospital or nursing home, etc., when people die of natural deaths. Medical examiners are usually exposed to about 25% of deaths within their jurisdiction. So the death certificate is a certification that the person has died, and within a reasonable degree of medical certainty, the certifying physician believes that whatever is on the cause of death line is the cause of death within a reasonable degree of medical certainty.
So let me ask you, in terms of this particular case, you've reviewed a substantial amount of information.
Yes.
Can you just briefly describe the information you've reviewed in this case?
Gosh, it goes on for several pages, but there are past medical records, the records that occurred in the hospital at or about the time that the attempted resuscitation of Mr. Floyd occurred. There are ambulance records, there are police records, there's toxicology information. There are multiple videos from multiple sources, both body-worn cameras, surveillance videos from stores, and other facilities in that area. There was video material from observers that is available. There's the toxicological data, there's the autopsy information, the autopsy photographs, the microscopic examination. It goes on and on and on. There is a substantial amount of information on this case.
And before we kind of get back to the death certificate in this particular case, upon your review and based upon your training and education, your experience as a forensic pathologist, have you formed opinions in this case to a reasonable degree of medical certainty?
Yes.
We'll come back to those shortly. So in terms of the death certificate, are there 2 parts to that?
Yes.
And can you explain those 2 parts?
So the first part is what the physician believes to be the cause of death. So that is something that you will put what we call part 1. That's what the CDC refers to it. The death certification process is one which is controlled and governed by the CDC, although each state will have a slightly different format to their death certificate and the way they do things. The guidelines that are put out there by the CDC for completion of death certification are certainly ones that are national.
So what's the first part of the death certification according to the CDC?
Well, the first part is the primary cause of death.
Right. And what's the second part per the CDC?
Other significant conditions contributing to death, but not directly related to what's in Part 1.
Now, I am going to ask, like to show Exhibit 193, which is already in evidence. You see that in front of you and ask to publish. You're familiar with this document?
I have seen this document, yes.
And what is the first part of the certification of death?
So the first part here, the cause of death, is cardiopulmonary arrest, complicating law enforcement, subdual, restraint, and neck compression.
Now, under that, there's a phrase that says underlying. Is that what you're talking about in terms of the second part per the CDC?
No, the way the CDC normally phrases it is you can break it out into multiple lines. So it could be cardiac arrhythmia due to such and such, due to such and such. And so that's where the underlying conditions come into the death certificate. At least, when you look at the CDC guidelines and the death certificates that I'm used to completing. The second part that I refer to as Part 2 on this death certificate is called other contributing conditions.
And what are the other contributing conditions that you review here?
And so on this particular death certificate, the certification says that atherosclerotic and hypertensive heart disease, fentanyl intoxication, and recent methamphetamine use are considered contributing conditions.
So this was prepared by Dr. Baker, correct?
Yes, that is my understanding, that he was the individual who certified this case.
So in terms of Dr. Baker's analysis of this case, how did the heart and drugs contribute to the cause of death?
They were significant, or they contributed to Mr. Floyd having a sudden cardiac arrest, in my opinion. That's how I would read it.
Okay. So I'm going to take this down. If we could unpublish, sorry. Doctor, did you prepare a PowerPoint presentation to walk through your opinions in this case?
Yes.
Judge, I identified this as demonstrative exhibit 1098, and I'd move to publish.
An objection to 1098 for demonstrative purposes only. All right, it is received for that purpose alone.
So before we begin, Doctor, can you summarize briefly what your opinions are in this case?
Yes. So in my opinion, Mr. Floyd had a sudden cardiac arrhythmia due to his atherosclerotic and hypertensive heart disease, or you can write that down multiple different ways, during his restraint and subdual by the police, or restraint by the police. And then his significant contributory conditions would be, since I've already put the heart disease in Part 1, he would have the toxicology, the fentanyl and methamphetamine. There is exposure to a vehicle exhaust, so potentially carbon monoxide poisoning, or at least an effect from increased carbon monoxide in his bloodstream, and paraganglionoma, or the other natural disease process that he has. So all of those combined to cause Mr. Floyd's death.
All right. So let's walk through each of these, if we could, starting with the opinions of Dr. Baker as far as the cardiopulmonary arrest. Before we do that, if we could publish the exhibit, Your Honor. Can you just describe what this is and why it's relevant to this case?
So this is a document that is produced as a guide for medical examiners to use when certifying the death, and specifically the manner of death.
What is the manner of death?
So the manner of death is how did the cause of death come about? And you have 5 different choices that you can check off or write down on a death certificate as to the manner of death.
Now, does this document specifically address asphyxial deaths, positional asphyxia deaths?
It addresses all sorts of manner of death, and again, it's a guideline put out there to assist medical examiners. And unfortunately, not every case cleanly fits into one particular category or meets the criteria for the guidelines.
Okay. So let's talk about, in terms of this second slide, positional restraint. How does NAME deal with the autopsies and death investigations involving potential positional restraint?
So the recommendation is that, or it's not a recommendation, they say you may be classified as a homicide.
Okay.
It doesn't say shall or should. It says may be classified as a homicide. Again, we have to recognize that these are medical guidelines. And it then goes on, and everybody, I think, can actually easily read that.
Okay.
If you want to go back one, and in such cases there may not be intent to kill, but the death death results from one or more intentional, volitional, potentially harmful acts directed at the decedent, without consent, of course. Further, there is some value to the homicide classification towards reducing the public perception that a cover-up is being perpetrated by the Death Investigation Agency.
Now, in terms of the 5 manners of death that you described, again, we've heard testimony, or the jury has heard testimony from other experts who've testified. There's homicide as one, suicide. Can you describe the others?
So homicide, suicide, accident, natural, and then undetermined.
So this next slide, can you describe what undetermined means according to the guidelines?
So according to the guidelines, undetermined, or the other term on some death certificates is could not be determined, is a classification that's used when the information pointing to one manner of death is no more compelling than one or more other competing manners of death, in thorough consideration of all available information.
And the guidelines also define homicide?
Yes. And again, homicide occurs when a death results from a volitional act, in other words, an act a person did, committed by another person to cause fear, harm, or death. Intent to cause death is a common element, but is not required for classification as a homicide. More below. It is to be emphasized that the classification of homicide for the purposes of death certification is a neutral term and neither indicates nor implies criminal intent, which remains the determination within the province of a legal process.
Why is that second part important?
Because this is a medical opinion that is on a death certificate. The manners of death are unique, or virtually unique, to the United States of America. These were put on the death certificate by the Center for Disease Control in order to gather information as to how Americans died or die for epidemiological purposes, and to study and try and prevent deaths. They are not meant to usurp any kind of legal process. And in fact, in many circumstances, regardless of what the medical examiner puts on a death certificate in the way of a manner, the legal system can and will act in a completely independent and different format.
Okay. Now, again, we discussed a little bit about the CDC death certificates. the instructions. Is this the guideline by the CDC?
Yes.
And it is to enter all diseases or conditions contributing to the death that were not reported in the chain of events?
In part one, in the first part, yes.
Now, back to, and if we could take this down for a moment, Your Honor. So with respect to Dr. Baker's autopsy, I just want to talk a little bit about the cardiopulmonary arrest that he references. What are the findings that were relevant to your analysis in this particular case?
There are substantial pertinent negatives in this particular case that drove my opinion.
What about the size of the heart?
So there are, again, certain pertinent positive issues. Mr. Floyd's heart was enlarged. There are multiple methods and studies that have been done on the size of the heart in the United States. There's one study out of the medical examiner's office in San Antonio, Dr. Molina and DeMaio, where they took a series of individuals who died suddenly with trauma and hopefully eliminated, as part of that process, natural disease that might have caused alterations in the heart size.
Excuse me, doctor, did you prepare a slide relevant to this, and if we could publish
Yes, I
it?
did.
Okay. So the Molina study you were referencing?
Right. So in their study, they found that 95% of males had a heart weight of between 233 and 383 grams. Anybody outside of those limits, and you would expect about 2.5% to be lower and 2.5% to be higher. That's the 95% certainty on either side of the mean. And so that is what they proposed as being the reference range for adult males.
Now, how about the Mayo study?
So the Mayo study is one where you can go in and calculate the weight based on the size of the individual, which is potentially more accurate, because you don't really want to take 130 pound, 5'5" male and say, and plug them into a particular range. You'd expect their heart to be smaller, as most of their organs would be smaller. And Mr. Floyd was a very tall, robust-looking individual. So I would expect him to have a larger heart. And so the type of study, such as the Mayo study, where they put in the sex of the individual, male, the height and the weight, and then come out with, as part of that calculation, accounting for that, the 95th inclusion rate would top out at 510 grams in this circumstance. So Mr. Floyd's heart weight at 540 is outside this range. I will tell you there are multiple studies. There's another one out of Chicago and Northwestern University, which has even broader range and would indicate that Mr. Floyd was within the 95 centile, but still right up at the very top end of normal. Bottom line is he has an enlarged heart.
Okay, if we could unpublish this, Your Honor. So in terms of, that's what you ultimately kind of see as relevant evidence here is that Mr. Floyd had an enlarged heart.
Yes.
How does the size of the heart affect the blood supply, nutrients, oxygen, things of that nature?
The heart is a muscle, and it's dependent on the supply of oxygen, glucose, and other important nutrients to function. When a heart or any other muscle grows in size, its consumption of those vital components increases. So Mr. Floyd's heart would have twice the need of those nutrients compared to a 260 gram heart or 270 gram heart, which would be halfway. It would be right in the middle of the Molina study criteria, because there's just twice as much heart muscle to support, and each of those cells is bigger and requires more oxygen.
So it's kind of like the law of supply and demand, right?
Correct.
All right. What happens to a person when they experience like a lack of supply, so to speak?
So like every other organ, the heart has certain reserves of energy built in. The typical amount of reserve in our brains is enough for us to maintain consciousness for about 10 to 15 seconds. And that is the organ which is most sensitive to constant supply.
The heart or the brain?
No, the brain. The heart is the next. But like other organs, it will be able to maintain function even when the supply is reduced or even completely cut off. But at some point, you do have to resupply, because those reserves are, when the heart is being exerted, are being used. And you either have to completely replace them, or if you only partially replace them, at some point, you're going to exhaust the reserves.
So how do we replenish the supply, so to speak?
The replenishment comes through the coronary arteries, and they bring blood into the heart. As that blood arrives, it delivers oxygen and other nutrients, and it also removes the byproducts of the metabolism of those heart muscles as they contract.
So what type of symptoms might someone who show if they are diminished in their supply?
So at some point, there are a variety of symptoms that can result. You can feel your heart racing. You may even get palpitations. You get potentially short of breath. And in some circumstances, you may start getting chest pain, what we refer to as angina. And it can get even worse than that. You can have sudden symptoms such as a collapse without any warning, but there's a spectrum of different symptoms that can occur.
So when the supply isn't being met, what would a person customarily do to replenish the supply?
Well, when one becomes short of breath, you tend to relax, ease up, back off, stop walking, stop running, stop exercising until such time as you feel like you've got your heart rate down. Some people monitor their heart while they're exercising to ensure they don't go over certain limits. So there are different ways of doing it, but typically, if you experience symptoms, it's your body telling you, slow down.
And what happens if someone doesn't do that?
If you don't, and you don't heed those warnings, or you can't heed those warnings for other circumstances, the consumption of those essential metabolites goes on. The production of the products of contraction, which need to be removed, continues to increase, and at some point the heart will fail, have a sudden cardiac arrest / arrhythmia. That's what you expect to see.
So, within the field of forensic pathology, what would you call the stopping of the heart?
We typically call it sudden cardiac arrest or cardiac arrhythmia.
What's the difference between sudden cardiac arrest and arrhythmia?
A sudden cardiac arrest really is an observational situation. You observe the person suddenly stop functioning. And usually the background process is an arrhythmia of some sort.
Okay.
Often starting out as a relatively benign arrhythmia and then progressing into a more malignant arrhythmia, which then decreases the function of the heart and eventually the heart fails.
Okay. So what types of things might cause a heart to be bigger like Mr. Floyd's?
The commonest one in the United States, which is part of the developing world, is hypertension. What we would call essential hypertension. It just happens.
And based on what you reviewed, did you determine whether Mr. Floyd had hypertension?
The size of the heart would be extremely good evidence that he had hypertension. Secondly, there are medical records that I did see where he had an elevated blood pressure. at previous hospital administrations or previous clinical interactions. So yes, there's evidence that he had that. And then there was something else found at autopsy, a tumor that is sometimes associated with hypertension as well in certain people.
That's a paraganglioma?
Paraganglionoma, yes.
Anoma, sorry. We will talk about that a little bit later. So just kind of generally, can you describe the major blood vessels of the heart?
Yes. There really are two major blood vessels, the right coronary artery and the left coronary artery. The left coronary artery, within a very short distance of coming off the aorta, divides into two major arteries, the left anterior descending and the left circumflex. So some people call it 3 coronary arteries, but technically there are 2 with one dividing into 2. Neither description would be incorrect.
And what is narrowing or stenosis of the arteries?
So narrowing or stenosis of the arteries means that the arteries, the lumen, the inside diameter of that artery is smaller than it should be. It has been narrowed by a disease process.
Okay. How does long-term drug use affect narrowing of the arteries?
There are certain drugs that do cause advanced or more rapidly advancing atherosclerosis. Not just drugs, but many substances and toxins, even smoking, for instance, is associated with earlier atherosclerosis. And certain drugs and other drugs, substances, can be added onto that particular dose. So even urban pollution has a risk of advancing heart disease.
What specific drugs?
Well, in this particular case, methamphetamine, which was present in Mr. Floyd, has been associated with earlier onset of narrowing of the coronary arteries by atherosclerosis.
And can you describe the difference between proximal and distal narrowing of the arteries?
Right. So the narrowing can occur anywhere up and down the artery. When it occurs close to its origin, i.e. close to the aorta where the blood supply comes from, we will call that proximal. If it occurs far down the artery towards the end of the artery or further down the artery, it's called distal. The implications are somewhat different. And if you have narrowing close to the beginning of the artery, anything downstream from that narrowing is subject to decreased supply of blood. If you have it further down in distal, then the first part and all the branches that come off the first part are supplying that heart, and that part of the heart will still receive enough supply. It's not restricted. But once you get to beyond the narrowing, any tissue, heart tissue, muscle, downstream from that is going to be subjected to a reduced supply.
Okay.
And so in this particular case, he had significant narrowing of all of his coronary arteries close to their origin, which really is consistent with all of his heart, unfortunately, being subjected to reduced supply, not just a portion of his heart, but the entire heart.
Is there a certain amount of narrowing that forensic pathologists consider to be enough to cause sudden death?
So the typical conventional number that forensic pathologists use is between 70 and 75% narrowing is a risk factor for sudden cardiac death.
Can you survive with greater than 75% narrowing?
Oh, absolutely. I have seen many, many cases where it can be 90, 95%. Again, it depends where on the artery it is. So a proximal narrowing is more dangerous than a distal narrowing because only part of the heart. And in this particular case, we know Mr. Floyd had 90% narrowing, so he was walking around with 90% stenosis beyond the 75, and that was not affecting him as part of his daily activities. So when he was at rest, walking around, doing his normal daily activities. I know of no information that he was symptomatic or having any problems. So yes, you can go beyond 75%.
That's why cardiologists may conclude you could survive with greater than 75%?
Yes, so I think the difference is that medical examiners see people who've died with 75%. And cardiologists see people who are walking around with 90%. So they see the live population, we see the dead population. And so we probably end up with different standards based on, unfortunately, that's what we see.
So in terms of an autopsy finding, can you describe what myocyte necrosis is and whether that's necessary to diagnose a sudden cardiac death?
So myocyte necrosis is both something you have to visualize it microscopically. You have to look at the individual heart cell. The myocyte is just a word which is heart cell. You can infer that there may be myocyte necrosis at autopsy if you see bleeding into the heart itself. But it is a microscopic diagnosis, and it is not necessary for myocyte necrosis to be present for a sudden cardiac death.
So someone who has a sudden cardiac death may not have myocyte necrosis?
Correct.
Why might that happen? Why might someone not have that myocyte necrosis?
Again, the heart goes through a process of dying. It takes a while for a heart to die and for the actual myocytes to start showing the changes that we can see under a microscope. I think we need to understand that that's why you can do heart transplants. And somebody who has been injured or suffered some other catastrophe to their brain and is brain dead and is a donor, their heart can be removed, put on ice, flown across the country and put into another person without any damage to that heart. And that process takes hours. So if the death is rapid, you will not see myocyte necrosis. It's the time frame from the heart stopping. So the time we typically see myocyte necrosis is going to be somebody who has had symptoms and survived for a period of time so that that process can advance to the degree where we can see it under the microscope.
Okay. Now, you've kind of talked about sudden cardiac events. Let's talk about the arrhythmia. Can you describe what is called the conduction system of the heart?
The conduction system of the heart is a very important part of the orderly contraction of our heart. We have two chambers which receive blood from the body, the atria, and then we have two bigger, very muscular chambers, the ventricles, that pump blood under high pressure to the body. And so the way the heart works is it's a two-chamber on each side. The one side supplying the lungs and the other side supplying the body, where the atria contract and push blood into the ventricles to fill them up. And then the ventricles contract to push blood to the body. The ventricles are very powerful, and there's a valve in between them to stop the blood flowing back. So what you need is an orderly contraction process where the atria contract first, followed by the ventricles. This is coordinated by the conduction system. And we have in the heart what is known as the cardiac pacemaker. It's a generic term, but it's the little piece of modified heart muscle that actually has almost nerve-like function.
Does that have a name? Sorry.
It's called a sinoatrial node. And that generates the initial activity which causes the atria to start contracting, and between it and another node which is at the junction of the atria and the ventricles, called the atrioventricular node, there is a little bundle of modified heart muscles that conduct that down, And then there are further modified heart muscles that go down to spread the impulse, the electrical impulse, to the heart to cause it to contract.
What are those called?
That's, it's the bundle of His, Purkinje fibers, etc. They will have medical terminology, but basically it's modified heart muscle cells. So what that does is the sinoatrial node fires, and the impulse is conducted down the fibers to the AV node. At that time, the atria contract, forcing blood into. At the time that the impulse arrives at the ventricles, that node then fires shortly after the atria, and the heart contracts and sends the blood on its way. So you get this orderly double beat to the heart. You can hear the valves opening and closing, atria first and then the ventricles, and that's the sounds that the physician listens to when he puts a stethoscope over your heart.
That's like the blood pressure?
Sorry?
Is that blood pressure? Or?
So the blood pressure is actually generated by the contraction of the ventricles. That's the essential output of the heart, is directly related to the volume and the pressure of blood that is pushed out of the heart.
Okay. So what happens if this conduction system gets impaired?
Then you don't have orderly contraction of the heart. And so if they fire at the wrong time, then if you had the atria and ventricles firing at the same time, you would move no blood. The ventricles are very powerful. They slam that valve shut. The atria fire at the same time. They can't force blood past it, and so you've got no flow to fill the ventricles.
And is that an arrhythmia?
That's an arrhythmia. So there are multiple different types of arrhythmias that are documented.
And what can happen, can sudden death happen as a result of an arrhythmia?
Absolutely.
So which artery supplies that pacemaker, the SA node that you described?
The sinoatrial node is supplied by a small branch that comes off the right coronary artery.
And did you review, again, the autopsy and observe findings relevant to Mr. Floyd's right coronary artery?
Yes, so unfortunately, that was the artery which showed the greatest degree of narrowing.
Which was how much?
90%.
Does that increase, or that type of narrowing increase the risk for sudden death?
Yes, in that if and when the blood supply needs of the heart on the right side increase, and that's also going to apply to the sinoatrial node, are not met, that sinoatrial node will not function properly, and will not fire properly, and you will end up with an arrhythmia of some sort.
So essentially, if it misfires, there's no pacemaker, right? Or
That is correct, yes.
how does exertion come into the analysis?
Exertion basically increases the demand for oxygen throughout the entire body, mostly because of the muscular activity. So as we exercise, our heart rate and our breathing rate normally compensate to increase the oxygen that we're bringing into the body through the respiratory system, and increase the amount of blood, or amount of oxygenated blood, which is being distributed to the body. And the way that increase of blood, the way the body increases the blood supply, is to increase the rate of the heart. So we will go from our resting heart rates, which are somewhere between 60 and 100, we'll push it up to 120, 140, 150, depending on the degree of exertion. And beyond, it gets dangerous.
So essentially, the more exertion, the more oxygenated blood is needed.
Yes.
How do drugs like methamphetamine come into play as far as the, in terms of the conduction system?
So methamphetamine is dangerous at several levels in this particular case. One, it has known arrhythmogenic potential. In other words, it sensitizes the heart to arrhythmias. It makes, it's just been documented that people on methamphetamine have an increased risk of an arrhythmia. Secondly, it increases the rate that the heart beats at. As a stimulant, it pushes the heartbeat rate up. So therefore, the heart is now going to demand increased oxygen, the heart muscle itself. And thirdly, it is a vasoconstrictor.
What is a vasoconstrictor?
So a vasoconstrictor is a substance which causes blood vessels, usually arteries, to narrow. And it's physiologically important, and it is protective in certain circumstances, but can become dangerous in others. And the way a vasoconstrictor works in most circumstances is to act on the muscular layer that's present in arteries. Our arteries have multiple different layers, and there's a muscular layer in there, and it causes that muscular layer to begin to contract. A little bit of contraction, that's good. Too much contraction, and it can slow down the blood beyond what is necessary, and even in certain circumstances you can stop the blood by giving a vasoconstrictor substance.
Okay. So in this particular case, we've got an enlarged heart, right?
Yes.
We have a heart that has narrowed coronary arteries, right?
Yes.
And based on your review of the video evidence, you observed a pretty significant struggle between Mr. Floyd and the three officers?
Correct.
Methamphetamine on board, which is a vasoconstrictor?
Yes.
Have you or your colleagues ever certified a death due to the atherosclerotic cardiovascular disease?
Yes, it's a unfortunately, very common cause of death.
And even at these levels of narrowing, 75 and 90?
Anything above 75%, as I previously mentioned, meets the criteria for enough narrowing, at least within the community of practicing forensic pathologists.
Have you ever performed an autopsy sort of expecting one cause of death but finding another?
That's why we perform autopsies. It is a thorough internal examination to identify anatomic deviations from normal, and so therefore your preconceived notion, a common, I wouldn't say a common example, but we see it every now and then, would be a motor vehicle collision where somebody has multiple injuries and you look at them and go, okay, they've got enough injury there to kill them. But when you go in, you can see evidence that they had a stroke or a heart attack. And that's what potentially caused them to lose control of their vehicle at the time that they had and got all their multiple injuries. And so then we sit with the issue of, do we put the heart attack under part 1, or do we put the heart attack and or the stroke type findings under significant conditions? Because obviously they were driving their vehicle, but it may have caused them to lose consciousness. So these are just dilemmas that we face as to where you put things on a death certificate. And sometimes you're not right and you're not wrong.
How about hypertensive cardiovascular disease? How does that relate to a cause of death?
So again, there are a number of sudden cardiac deaths that are related solely and exclusively to the increased size of the heart. And so those are the ones that, since hypertensive disease is the most common cause of an enlarged heart, we will typically use that as the cause of death and say hypertensive cardiovascular disease.
Have you ever certified a death due to hypertensive cardiovascular disease?
Yes, I have, multiple times.
Have you diagnosed both hypertension and coronary artery disease as a cause of death in combination?
Yes, and again, that is probably even more common because a significant proportion of the population have hypertension, so their hearts are enlarged, and as you get older, you tend to lay down deposits of material in your arteries, and so there's often both are present in many cases, unfortunately.
Now, again, in terms of hypertensive cardiovascular disease, we talked earlier about kind of the struggle between Mr. Floyd and the officers getting into the squad car. How does that type of exertion play into hypertensive cardiovascular disease?
It increases, both with the hypertensive and the atherosclerotic, it increases the demand and the stress on the heart. And the more the individual is stressed, both physically and in other ways, the more the demand on the heart is going to increase.
So in terms of stress, right, how does that affect the heart?
So we have certain innate stress mechanisms built into us, reflexes built into us. It's called the fight and flight reflex, is the common terminology that you will see within the medical literature and also within the lay literature. And this is a mechanism where if you are in a stressful situation, it prepares your body to be able to cope with the stressful situation. And what happens generally is the sympathetic part of your nervous system begins to act. That causes secretion of adrenaline as one of the examples, and perhaps other catecholamines, which are substances that are part of that sympathetic nervous system. And adrenaline causes some of your blood vessels to constrict. It's another potent vasoconstrictor. The idea being that you don't need to digest the food in your stomach, for instance, while you're in a very, very dangerous environment. So it really shunts the blood, pushes the blood to the organs that are more important: the heart, the lungs, the brain, your muscles. And also shuts down the blood supply to your skin. So it does all of those things. But it also speeds up the heart to increase the cardiac output to maintain oxygenation of the brain, your muscles, and other things, so that you can have an additional reserve to fight that threat.
All right. Now, so the fight or flight kind of that you described, it increases adrenaline, right? It causes the heart to beat faster. Agreed?
Yes, and yes.
And the adrenaline, how does that come into play? Did you say that was a vasoconstrictor?
So adrenaline is a vasoconstrictor, yes.
Including the arteries?
Oh, yes.
And ultimately, what does that do potentially?
So it narrows the arteries, and again, we have smooth muscle in the cardiac arteries. So there's a potential of the adrenaline and the methamphetamine further narrowing those arteries in the heart, as well as arteries elsewhere in the body, restricting blood flow.
Now, in terms of that kind of stress reaction, I would like to craft this question carefully. The jury saw some evidence, which I know you reviewed as well, of an incident in 2019, about a year prior to Mr. Floyd's death, where Mr. Floyd was stopped by the police, was seen or believed and admitted to ingesting some controlled substances at that point, and was subsequently seen by paramedics. Do you recall that information in the information you reviewed generally?
I did.
And at the time that he was initially seen by paramedics, his blood pressure was taken, and if I'm not mistaken, it was 216/160. What does that signify to you as far as this stress relation?
So a high blood pressure like that, and that's markedly elevated, could be due to his hypertension being out of control. But this is much higher than I would expect. Secondly, it could be part of the stress reaction where adrenaline is being secreted and it's pushing his heart rate up, and that will increase your blood pressure. And if adrenaline is secreted, it's also causing vasoconstriction, so there's more blood staying within the central vasculature, and so therefore that will also increase your blood pressure. There are multiple explanations for that, but certainly stress would be one of them.
Okay. Your Honor, I believe that right now would be a good time for our mid-morning break.
Members of the jury will take 20
Minutes, let's reconvene at 11:10.